Hi, it's Tom here from Running Physio. In today's video, I'd like to talk to you a little bit about plantar fasciitis, or probably more correctly called plantar heel pain, and how not all pain around that region is going to be coming from the plantar fascia. So we're going to explore some other potential causes, and we're going to look at 3 case studies where there was something else going on and actually reaching a different diagnosis informed and changed management, which is really important because diagnosis on its own isn't necessarily the thing. It's whether it's important to that individual and whether it changes their care. So let's start by thinking about what we might expect as your typical presentation of plantar heel pain, because this helps us to identify it, because actually a lot of the diagnostic process will occur with the history. So typically with plantar heel pain, we might expect the patient to be between about 40 and 60, roughly speaking. You're going to get some variety in this. You might see it occur in younger people if they're very active and athletic, perhaps, but your typical age group is 40 to 60. It is usually a gradual onset, so we start to develop pain over time. And that's often related to changes in activity in our athletes, but in non-athletes and sedentary individuals, you might actually see it linked to obesity and other health factors. If you have a sudden onset of plantar fascial symptoms, a sudden sort of tear or kind of pop sensation, we might be looking at a plantar fascial rupture. So that onset is going to be part of your kind of reasoning process. We would expect the pain to be localized to the medial tubercle of the calcaneum, and you would expect it to be sore on palpation there. Key signs of plantar heel pain, you are going to have, for most people, early morning stiffness and first step pain. And if that's not there in your patient who has heel pain, it would, for me, make me wonder about whether we're looking at a diagnosis of plantar heel pain or whether there's something else going on. You'll often see stiffness after inactivity. So if someone sits for a long period of time and then gets up, they'll often have pain and stiffness. And you can get a warm-up response with movement. So as people get going, it starts to feel a bit better as it loosens things off. It behaves very similar to a tendon, and actually in terms of its pathology, it's quite similar to an insertional tendinopathy. So just like a tendon, it might also flare up after activity as well, sometimes even the next day after activity. So if you're seeing these kind of typical behaviors, early morning stiffness, first step pain, stiffness after activity, pain located to the medial tubercle of the calcaneum, this is all making me thinking this is consistent with plantar heel pain. You may also get pain with stretching the plantar fascia, such as passive toe extension, particularly if it's combined with ankle dorsiflexion, but in clinic this does seem to depend on how irritable the patient's symptoms are. In non-irritable cases, I've often found this isn't especially painful as a test to do. So those might be some of your typical findings, and of course we know patients don't always follow the rules, but we'd expect to have some, or at least perhaps most of those features in there if we're looking at diagnosing plantar heel pain. And some of those key ones like early morning stiffness and first step pain are going to be present for most patients. Now, if they're not present, we really need to start to think about other differential diagnoses. If it's a different location of pain, if it's different pain behavior, or even if it's a different population that we don't tend to see it in, like obviously younger athletes or children. Now, in terms of the differential diagnosis, this is an image we've adapted from a really nice paper by Hossain and Makwana in 2011, which I really recommend having a look at. I'll put a link to that in the comments afterwards. Now, these are approximate areas of tenderness for some of the other potential causes of pain around the kind of medial foot and heel region. They are approximate, so please don't message me saying they're not 100% accurate. They're as close as we could get it. Now, we have, at the top here, we have the medial malleolus, potential source of symptoms. And of course, remember, you've got the tendon of tibialis posterior winding around underneath that, which can cause pain in this region too. The 3 green circles highlight potential neural causes of symptoms in this region. And some research suggests as much as 15 to 20% of people with plantar heel pain will have some neural involvement. So look out for the signs of that, perhaps more diffuse pain, burning sensations, alterations in sensation, etc., which might lead us towards thinking there's a neural component. And for most people with plantar heel pain, I will look at straight leg raise and slump and some of the tests for more of these local nerves, just as a process of narrowing down the diagnosis. Now, we can see here we've got the rough approximate areas of tenderness for this. So where you see TTS, that's where we might expect it to be tender for tarsal tunnel syndrome. Just beneath that, you've got MCN, the medial calcaneal nerve compression, and next to that, BN, which is Baxter's nerve compression. So these might be where we'd expect to see some tenderness with these more kind of neural causes. Beneath that then, IPF, this little red circle is where we might expect to have pain with plantar fasciopathy, with insertional plantar fasciopathy, which is more commonly what we will see in clinic. It's normally pain at that insertion at the medial tubercle, and you're likely to recreate some pain on palpation in most patients, although not every patient, and they'll usually point to this region as a potential area of symptoms. You can have non-insertional plantar fasciopathy, highlighted here with our little red kind of little sort of shape there with NIPF in it. So that's where we might expect your symptoms if it's non-insertional, more through kind of the mid portion of the plantar fascia. And then just above that, a little blue circle we've highlighted there as NAV. That's roughly where we might expect to see some pain if we have some navicular involvement, possibly something like a navicular bone stress injury. So this gives you a rough idea of where we might expect some of these pain locations. Of course, it doesn't cover everything. We've also got the calcaneum itself to think about. You can have calcaneal stress fractures, which also will cause some pain in that region. So a little bit of an overview there of some of the other potential causes of pain are roughly around this region. Next up, I want to think about some case studies and some people we've seen in clinic to highlight how this can actually be important for their management. So first up, we have a 17-year-old athlete who has been treated for some time elsewhere for plantar fasciitis. She's got activity-related pain, so it's often worse during her sport and can linger then afterwards. But she doesn't actually have early morning stiffness. She's got quite important past medical history because she had osteomyelitis in that foot as a child. Now, so far, it's been treated as a plantar heel pain and it's not really improved, which is why they've come to see us as a second opinion. Now, already, hopefully, you're picking up on some of the things here that don't really fit a classic plantar heel pain. It's not really that common in a 17-year-old athlete. So already we're thinking, is that really the likely cause? There's no early morning stiffness or first step pain, which is making me think, well, what else might potentially be the cause of symptoms here? She has this past medical history, which would make me suspicious of a bone stress injury. If you've had previous problems with bone health, it can increase your risk of getting future issues there. And her pain isn't so much over the PF insertion, it's actually more over the navicular. So another thing you can do in clinic is be quite thorough with your palpation around that region. Include bony palpation wherever you can, around the calcaneum, around the navicular, etc., because that can help you point you a little bit more towards bone stress injury, particularly if the bigger picture fits. So in this case then, it's not really resolving. We've got this relevant history. An MRI was arranged and it did show a navicular stress fracture. Now, these are considered to be high risk because they can go on to develop avascular necrosis. So these need to be managed quite differently. And I believe in her case, she was put in a protective boot for a period of time to help the healing process. So with these, it can be worth pursuing differential diagnosis, something like an MRI, particularly with a potential high-risk stress fracture. So that's our first case study, shows different management was needed, not just continuing down the route of treating it like a plantar fascia issue, even though it's not really presenting like that. Case study number 2, a patient that I've seen fairly recently who had heel pain again and was told it was plantar fasciitis. So she'd been treating it as plantar fasciitis with lots and lots of stretching every day. She'd be putting it in a boot, like a stretching splint, to really stretch that plantar fascia out. And it just wasn't getting any better. In fact, the stretching and things, if anything, were aggravating it. Now, in her case, when we got her to really point to where the pain was, and I'd recommend you do this as part of your differential diagnosis, really get the patient to point and lay their finger on the center of the pain, we actually found it wasn't the plantar fascia at all. It was at the Achilles insertion where there was swelling and there was tenderness. And we could palpate quite deep into the plantar fascial insertion without bringing on any symptoms at all. Now, she had the other sort of features like early morning stiffness, but that's because actually this was an insertional Achilles tendon issue. Now, again, you can see here it changes management, because we know really with insertional Achilles pain, if you aggressively stretch them, it really aggravates symptoms. So in this case, it was a question of backing off from these stretches, which were being used really regularly alongside a splint to stretch into dorsiflexion, and looking at other strategies rather than pursuing aggressive stretching that was really aggravating. So again, you can see differential diagnosis here, particularly around the pain location and tenderness on palpation, that really would change management. Now, the final one is, I think, quite an interesting one, probably less common, but something to be aware of. So this is a patient with bilateral plantar heel pain. They have a history of psoriasis as well, and they have a history of nail bed psoriasis, which looks a little bit like this. So what you'll often see is you'll see discoloration with the fingernails. You'll see sometimes pitting in the fingernails as well. And now this, if it's present with psoriasis, is associated with a greater risk of psoriatic arthritis. So it is something to notice. Now, this patient has bilateral symptoms, which again should wave a little flag. You can get them, but bilateral plantar fascial symptoms, similar to bilateral insertional Achilles symptoms, should make you a little bit suspicious of a more systemic cause to their problem. Now, they'd also said that they had general early morning stiffness that seemed to last quite a long time for them in the morning, and they'd had these episodic flare-ups of finger pain, particularly when their nail bed changes were worse. They'd get pain and swelling in the distal interphalangeal joints, and sometimes at its worst, they'd get dactylitis, which is swelling of the whole finger. Now, these are all potentially features of psoriatic arthritis. And this patient also reported their symptoms did tend to improve with anti-inflammatories, which again is something that suggests an inflammatory component. So we think in this case that perhaps it's an underlying psoriatic arthritis, which has led to inflammation of the plantar fascial insertion at its enthesis, and therefore the appropriate next step is to arrange an appointment with a rheumatologist. They would look at bloods, at HLA-B27, at X-rays, potentially ultrasound of that plantar fascial enthesis and other areas too, to see if this actually is a psoriatic arthritis that's driving the symptoms and needs appropriate management. And I think really, if you suspect something like psoriatic arthritis or any of these inflammatory joint diseases, it's worth arranging investigations fairly soon, because we know that some of these conditions can be associated with long-term joint changes. So let's get those tests and things done quickly, so hopefully we can rule it out. But if not, if it's present, we can start a treatment process. We can team up with a rheumatologist and hopefully get the best results for patients. Okay, so that's a sort of speedy overview of plantar heel pain and some of the other potential causes there for you. I think when we do the assessment, that history is so important, and hopefully for the most part you'll be able to identify those typical presentations we've talked about. But when it doesn't really fit there, we do need to think about other potential causes. Systemic causes like things like our spondyloarthropathies, but also potentially bone stress injuries, neural causes, tendinopathy, etc. So we want to think a little bit more outside the box in these cases. Okay, I hope you found that helpful. I've put a link to our new tricky tendon video series, which is all about tendinopathy and how to assess and treat that. That's free, so do follow that link, and I'm sure you'll learn loads from that. And if you've got any questions about this, do let us know. If you find these videos helpful, please do like them and share them. They are for you. We want to get them out there and help as many people as we can. Okay, thanks again for listening. Bye for now.